My name is Azra.
I teach art and architectural history here, and I've been given the responsibility, to my great pleasure, of welcoming you and introducing the speakers. So, a very warm welcome to the 9th session of the Two Cultures Initiative, and my heartfelt gratitude for your presence here. The Two Cultures Initiative is an interdisciplinary forum spearheaded by Professor Basit Koshul, who will be on the stage in a minute, intended to bring together scholars from fields physically and intellectually imagined to be far away from each other. The aim of this initiative is to build bridges for collaborative inquiry of reconnecting knowledge systems that can complement each other for ourselves and our future, that is, our students. In today's session, we have two brilliant scholars, titans I would like to call them, reigning over several domains, who will engage in a conversation that promises to answer questions we all have related to illness and the suffering it brings, of strength, both physical and mental, that is needed to navigate through these difficult and dark alleys, of hope and healing, different literature and art forms promise to bring us. Dr. Azra Raza, as we all know, is a cancer specialist, professor of medicine and clinical director of the myelodysplastic syndrome, I hope I've pronounced it correctly, Center at Columbia University. Dr. Raza has published extensively in top-tier journals and authored the critically acclaimed book that you all have the good fortune of getting signed by her, The First Cell and the Human Cost of Pursuing Cancer to the Last. Accepted and admired, and reviewed as, and I quote, no ordinary book of medicine, but a book of wisdom and grace by an author who has devoted her life to making the unbearable easier to bear, end quote. The range of her scholarly pursuits is evident from another publication she co-authored, Ghalib Epistemologies of Elegance, showing her literary engagement with Urdu poetry. And I must stop here and thank Babar Saab for making Dr. Raza's presence among us possible. She will be in conversation with Professor Basit Koshul, our very own professor, who has not one but two PhDs. So I like to call him Doctor. One from Drew University in the Sociology of Religion, and the second from the University of Virginia in Theology, Ethics, and Culture. He has the honor of being the first faculty member of the Department of Humanities and Social Sciences at LUMS to be promoted to full professor in 2018. His research areas span the area of religious studies, philosophy of science, and sociology of culture. He is especially interested in nurturing a conversation between the falsafa-e-khudi of Allama Iqbal, the pragmatism of Charles Peirce, and the social science methodology of Max Weber. Before we go to Professor Azra Raza and Professor Basit Koshul, please allow me to invite Professor Muhammad Sabih Anwar, another pioneer of the Two Cultures Initiative. So he introduces this forum in some more detail. Professor Sabih is a professor of physics who has served as the Ahmad Daud Chair and former Dean of the LUMS Syed Babar Ali School of Science and Engineering, and his research interests, beyond quantum physics that he specializes in, include the culture of science in the Muslim world and science education in developing economies. As part of the Khwarizmi Science Society, he leads one of the region's biggest science festivals called Lahore Science Mela, which combines scientific and cultural capitals in an inviting show for thousands of visitors. With that, Professor Sabi Anwar.
बिस्मिल्लाहिर्रहमानिर्रहीम. शुक्रिया डॉक्टर नदरा. आपको जो इस वक्त तस्वीर नज़र आ रही है, इसमें दो शख्सियतें सामने. एक शख्सियत इनमें से उनकी तस्वीर फ़र्ज़ी है मेरे ख़्याल में, लेकिन जो तस्वीर फ़र्ज़ी नहीं है, जो असली है, क्या आप में से कोई पहचान सकता है वो कौन है? चलें, जो फ़र्ज़ी तस्वीर है वो मौलाना रूमी की है. ज़ाहिर है हमारे पास मौलाना रूमी की कोई असली तस्वीर शाज़ ही मौजूद हो, इसलिए ये एक मुसव्विर का वहम है या गुमान है कि रूमी ऐसे होंगे. लेकिन जो दूसरी तस्वीर है वो एक मशहूर रियाज़ीदान की है जो फ़लसफ़ी भी था. क्या आप पहचान सकते हैं? यह है गोडेल. तो दरअसल ये तस्वीर टू कल्चर्स इनिशिएटिव का एक खुलासा है. टू कल्चर्स इनिशिएटिव जब बासित कोशल साहब ने पिछले साल कायम किया, हमें शरफ़ हासिल हुआ कि स्कूल ऑफ साइंस एंड इंजीनियरिंग में उसकी मेज़बानी करें इस इनिशिएटिव की. बुनियादी मकसद यह था कि जो साइंस और अदबियात, साइंस और फ़लसफ़ा, साइंस और कल्चर, इसके दरमियान जो बड़ी एक खलीज कायम है उसको कैसे पुर किया जाए. जो एक ख़याली, जो एक फ़िक्री बोध मौजूद है, उस बोध को कैसे करीब लाया जा सकता है. मैं फ़िज़िसिस्ट हूँ. मैं जब क्लासरूम में जाता हूँ, मैं क्वांटम फ़िज़िक्स पढ़ाता हूँ. बड़ी दकीक मिसालें, रियाजी की मिसालें हैं. एक कोई लगता है कि कोई अदक ज़ुबान लिखी जा रही है तख्ताए स्याह पे, और उसको समझना बहुत मुश्किल होता है. लेकिन जब मैं क्लास के आखिर में सवाल पूछते हैं स्टूडेंट्स मुझसे, तो मुझसे सिर्फ फ़िज़िक्स के सवाल नहीं पूछते. मुझसे पूछते हैं आखिर ऐसा क्यों हुआ. क्या इस सारे ये जो आप हमें बुखारात की दुनिया और मुमकिनात की दुनिया दिखा रहे हैं, क्या इससे हम अपने नफ्स को पहचान सकते हैं? क्या इससे मावराए फ़ितरत हमारे जो एहसासात हैं, जो ख़यालात हैं, जो इमोशंस हैं, क्या हम उनकी दुनिया तक पहुंच सकते हैं? इसका मुआशरे में क्या असर होगा? इस साइंस का मुआशरे से क्या ताल्लुक़ है? इंसानी आज़ादी से क्या ताल्लुक़ है? इंसानी नफ्स से क्या ताल्लुक़ है? तो यही मकसद था टू कल्चर्स इनिशिएटिव को कायम करने का, कि ये जो एक दूरी पैदा हो चुकी है साइंस में, मलकूत के इल्म में, यानी जो चीज़ ज़ाहिर आपकी आंखों के सामने है और जो पोशीदा है, उसके दरमियान जो एक तफावत है, उसको कैसे दूर किया जाए. तो पिछले एक साल से मुख्तलिफ़ तरह की महफ़िल का एहतमाम किया जा चुका है टू कल्चर्स इनिशिएटिव के फ़ोरम पर. ये मुकालमे भी हैं, ये बहसें भी हैं, इसमें शेर व शायरी भी है. इसमें अगर मैं आपको पिछले साल की जो रुदाद है उसकी एक स्लाइड दिखा सकूं तो शायद आपको बेहतर अंदाज़ा हो सके. ये पिछले साल की एक झलक है. तो अगर आप देखें पिछले सेमेस्टर में जो मौज़ूआत थे उनका ताल्लुक़ खुदागही से था, खुद शनासी से था. आप जानते हैं कि खुदागही कितनी अहम चीज़ है. अपने नफ्स को देखना, मुआशरे में, कायनात में अपने मकाम को पहचानना, ये एक ऐसी खुदागही ऐसी चीज़ है जिसके बारे में इकबाल कहते हैं कि खुदागहाँ अज़ीं के खाकदां बुरूं जस्तंद, कि आप एक खाकदान से बाहर निकल के एक आलम बाला की सैर कर सकते हैं अगर आप खुद ही को पहचान लें. तो द कम्युनल सेल्फ पर एक मुकालमा था. फिर हमारे बासित साहब ने द मॉडर्न सेल्फ पर एक नहायत खूबसूरत 2 लेक्चर्स का एहतमाम किया. साइकोलॉजिकल सेल्फ. फिर MIT के प्रोफेसर जेम्स वेस्टकोट ने बॉडी, वाटर और गवर्नेंस पर एक तकरीब का एहतमाम किया. और द साइंस नीड फ़िलासफ़ी, ये साइंस और फ़िलासफ़ी का जो संगम है उस पे बात हुई. और फिर महमूद शबस्तरी की जो किताब है गुलशन राज, और अल्लामा इकबाल ने जो इस पे तज़मीन की गुलशन राज जदीद, उस पर एक बड़ा खूबसूरत मुकालमा हुआ. तो ये टू कल्चर्स इनिशिएटिव के पिछले साल के कामों की कुछ एक मुख्तसर सी झलक है। आज की तकरीब ज़ाहिर है एक नहायत ख़ूबसूरत बावकार तकरीब है। हमारी आज की ख़ास मेहमान एक आलमी शोहरत याफ्ता एक साइंसदान भी हैं, लेकिन इस साइंस को अदब के साथ, नफ्स शनासी के साथ, आफाक शनासी के साथ जानने का गुर भी जानती हैं। तो अब मज़ीद कुछ कहे बगैर आप सबका एक बार फिर बहुत शुक्रिया, और उम्मीद है आप आज की महफ़िल से खूब सोच भी उठाएंगे और लुत्फ़ भी उठाएंगे।
Yeah, assalamu alaikum. I will not take any time to be between you and Dr. Saiba. I know that you're here to listen to her and benefit from her. With your permission, just a little bit. What a book! What a remarkable piece! And I came across it about a year and a half ago, and I just the title itself is quite eye-opening, and I recall just reading the back flap or something like that. I had not even read the introduction yet, and right away I said, we need to have Dr. Azra come to LUMS, and especially at the forum of the Two Cultures Initiative, because just the back flap itself was enough. So we contacted her, and she said, well, I have already done my one trip to Pakistan this year. The next time I come, please get in touch. And Dr. Saiba, we did, and so thank you so very much. In the midst of an incredibly busy schedule, I think you have a minimum of 2 presentations per day, like 2 official presentations, and we will not talk about the personal and the visits and all of that. And wonderful to see your colleague, Dr. Bustini. What a team you are! What a team you are! That you have graced us with your presence. Okay, Dr. Saba, I will begin here. The Edmund Pellegrino. He has said, medicine is the most humane of sciences, the most empiric of arts, and the most scientific of humanities. And I think it just beautifully captures what it means to be a doctor, to be a practicing doctor, whose quote-unquote object of inquiry is a living, breathing human being who has developed an illness. And this is the way Pellegrino describes medicine. And if you could, from your book, maybe an example of how is it that medicine is the most humane of sciences, from your personal experience, from the book, that what is it that makes medicine a humane science, or demands that the medical practitioner be a humane person?
Adab, and thanks to all the people who've been coming over and over to hear my 2 talks a day. It's such an honor and a pleasure to be at LUMS. It's my first visit here ever. And it's been a fantastic eye-opener for me to see so many incredibly talented and exceptionally well-trained people, but who are original thinkers, who are really charting new courses here. This whole idea of the Two Cultures Initiative is such a timely thing for us, because we seem to be losing that trend. And I congratulate all of you, and I am particularly honored to mingle and to have a chance to interact with the students of LUMS. Professor Kusteni, who's my colleague at Columbia University and a well-known professor and a well-acknowledged scientist, cancer researcher. she has also had the best experience with students and faculty, of course. So on behalf of both of us, we'd like to extend our gratitude for this invitation and look forward to coming again, inshallah.
Inshallah.
Your question is a very good one, of course, about the importance of empathy and how medicine is a humane science. It's in fact the most social of sciences. If you think about it, as a new patient comes to see us, startlingly, within minutes, they begin telling us the most intimate details about themselves. And it's a humbling experience, because what you realize is that disease has had some form of a disorienting effect on the individual. And as they're trying to recount their story, it's quite fragmented. Their stories change from week to week, and then from mouth to mouth, because the patient will say one thing, but the family will deny and say something else. And symptoms change from signs back to symptoms. And what you realize is that there's such a great responsibility for the physician to read between the lines, to be able to make sense of a story and then recount it in the chart of the patient in such a way that the next person who's going to read it will be able to get the gist of it. And I always feel somehow anxious about this narrative aspect of medicine and understanding the social components that are surrounding the disease process, which makes this intermingling of a very clinical interaction along with a very social interaction, where one has to seamlessly chart a course, not just for yourself, but for future clinicians who are going to be reading that chart. And so I always say to my students at Columbia that in order to even get the patient's story, you need to hear more hearingly. You have to, like the blind, develop an extra power of hearing. It's not just the words that the patient is saying, but the body language, the expression. And so I think read the anxiety that's coming across. And to me, the social interaction part is very much dependent on how you are reading the patient and what is their need and how are you going to offer the best possible support for that particular need, which differs from patient to patient and the family, because especially the kind of disease I am dealing with, cancer, affects an individual, but the ramifications are on the whole family, in fact, on the community, essentially. And so the interconnectedness of the disease, the violations of the psychic energies, all these things have to be taken into account and then narrated properly and reacted to properly. So it's a very complex system that has to be navigated.
As you're speaking, and it just occurred to me, so this is not just an interaction between the doctor and the patient. One of the things, first of all, you have to have a special skill, right? To read between the lines, as you said. But you also mentioned something about the chart, that you have to then put your observations down in black and white, knowing that that chart will go into the hands of one of your colleagues.
Yes.
And that they will also, that how important that it is, you're not only in conversation with the patient, you're also in conversation with your colleague who will follow you in the, later on or in another department. And I guess that means maybe where, quote unquote, the scientific part comes in, that that black and white into which you have, whatever you have read between the lines, now it has to be translated into some black and white, someone who has not seen the lines yet, but they will see them later. So you have to put it in that language. So that's a very different skill that is needed, without which one cannot be a good doctor. Is that inaccurate?
Very accurate. In fact, when you ask me, it's a social science, I don't want to limit it to some sympathetic, empathy, compassion interaction, because there's so much more to it than just that exchange. By the way, has anyone seen The Crown, that series? Okay. So in The Crown, they show the life story of Queen Elizabeth, and she knew that she's going to be the next queen when she was 13 years old. And from that moment on, her training was that she is above average. She is divinity. She must not interact with common people. So she had to maintain a distance from everyone. But on the other hand, there was some kind of an avalanche and 60 children died, and she was expected to go and show her sympathy. And when she didn't go because she was so scared, because she felt like she might break down and she can't afford to because she's supposed to maintain her distance. And she didn't go. And immediately the public got very angry and they started dissing her, so she had to go, and then she did break down. It's that seeing that episode, Basit, reminded me very much of the fact that as doctors, you know what we are trained to do is not to allow our emotions to become involved with the patient, because emotions cloud judgments. That's the understanding of science. And if judgment is clouded because of emotions, you can't make the right decisions for the patients. That's what we are told to do. Don't let your emotions get in the way. But what does the patient expect? Patient expects empathy from you, sympathy from you, understanding from you, a show of emotion from you. And I feel like that same dichotomy exists a lot, because it's supposed to be the most social interaction in a way. And yet you are trained not to be that social. And I don't understand this kind of an internal contradiction within the training process of medicine.
Well, so in order to be a good doctor, you have to have an artistic sense, an aesthetic sense. You have to have a scientific sense, an empiric sense, and you have to have that social sense and the humane sense. If these three things do not come together,
Yes,
you cannot be a good doctor. And Dr. Saab, you're a very good doctor. You're like, and yeah, obviously we're not saying this because you are among us. There's a 40-year track record of this. That how in order to be a good doctor, these three elements, which are maybe worlds apart, they're integrated in one person. And I think as going through the book, it looks like it's a lament that how these three elements have become separated from each other. And then a good part of the book is the consequences of this separation.
yeah.
And the first thing is you've already alluded to it, that in your training as a doctor, when a patient comes in, that is not a unique individual that is walking into your office. That is not the priority for the doctor. The doctor's priority is there's a set of protocols, there's a set of guidelines that will determine a priori how the doctor is supposed to interact with this unique individual. So irrespective of the uniqueness in the individual that comes in, the guidelines are, quote unquote, universal. So we have this thing where the universal guidelines take precedence over the uniqueness of the case that is in front. So with your permission, right, I would like to quote from your book, that points to this characteristic of now how medicine is actually practiced or actually taught. Before how it is practiced, how it is taught. The medical student, before they ever see a patient, they have already been trained that this is how you will deal with the patient. And you say, experts have devised formal criteria for best practices, and any nonconformity could leave the deviant open to legal challenges. While evidence-based medicine is essential, it is not sufficient by itself when caring for individual patients. This is from your book. Now, what I would like to ask is, are universal treatment guidelines sufficient for providing effective care? Why or why not? And how might they fail to address, or how have they failed to address the nuances in individual healing, in your experience?
I think simply stated, when guidelines of any sorts are made, the guidelines have to depend on solid data. But what are the data that we are looking at? If 100 patients had this particular form of disease or this particular symptoms, and we gave them this drug, then 20 will have a good response, 80 will not. So we can say to the patient, 80% chance is not good, 20% chance you'll respond. But then the patient asks me, okay, which part am I on? Am I 20% or 80%? We don't know. So you see, you have the guideline, but then how do you apply it to the individual? A patient comes to see me, I give them the diagnosis of pre-leukemia. Let's say some 60-year-old comes and has low blood counts, and I do a bone marrow and I diagnose that they have pre-leukemia, and at some point they could develop leukemia. The very common question is, okay, you're giving me a diagnosis, so doc, what does that mean? Should I be completing my bucket list right away? Or can I plan to attend my grandson's graduation 3 years down the line? What is it you're telling me? And I have to say, I don't know.
How does that feel? How does that feel when you say you don't know and you see the look on the face of the patient? Because if they can't get a kind of a quote-unquote answer from you,
that's the issue, that this is a discussion between you and me. But if there is a patient across from me, then Emily Dickinson's words are the best. Tell all the truth, but tell it slant. You have to be. And that's why the first part of the question was so important, that it is a social science also, that you need to understand what the patient will be able to absorb properly. Because you see, the patient is, I can tell them 10 things, but they will register only the 2 or 3 things that they find are giving them a positive signal. They will put everything out of their mind that is not fitting into a predetermined cognitive bias that they have come in with. So one has to venture into unknown territory, but gently. And the way to say it to the patient for me would be that, look, it's a good question that should you be preparing to die right away, or can you plan for things? I always say that for me, I'm prepared to die tomorrow. But I live as if I'm going to last many years. And you shouldn't change that policy for disease, because disease itself is unpredictable. And anyone who tells you they can predict a precise time of your death is lying or deluding you. Because again, we can say that 40% chances are you'll do this, 37% chances are you'll do that. Nothing is fixed. And therefore, a patient's individual natural history of the disease is far more important than any presenting symptom.
Yeah, but in the way that the future doctors are being trained, how important in their training, how much emphasis or how much importance is the individuality of the patient? How much of that is a part of their training / education? The way you have charted that space, right, between the protocols and the standards on one hand that have to be followed, but obviously there's a judgment call, whether you're in the 20% or the 80%. Now, there are no guidelines, I guess, right, that will help the doctor determine that this particular patient is in the 20 or the 80%.
Yeah.
Now, what does a young doctor or an aspiring doctor, how is it that they learn, where will they learn the importance of that, the role that they will play, the role that they will play in filling this gap?
You know, there are lots of doctors in my family. In my immediate siblings, 4 of us are doctors, everyone married doctors, and then lots of children have become doctors. And one of my nieces, who's an oncologist in Providence. So a thing about AI is going around in my family on texts right now. And my niece, who is an oncologist in Providence, just this morning sent a text saying, well, I used to work at Brown University. She was there for several years, and now she's moved into a private practice. And she said, in this private practice, you know what happens? I go into a room, and I'm seeing the patient for the first time or the 10th time, doesn't matter. I'm talking to the patient, interviewing the patient, asking them their family history, social history, past history, their symptoms, their signs, etc. And then I don't touch any computer, nothing. I come out and AI has been listening to the conversation and constructed a beautiful narrative for me. Based on that conversation, the entire story is printed out as she walks out of that room. And all she has to do is scan it and maybe 1 or 2 corrections, and that's it. That is the chart these days. That AI is actually listening to the conversation and making these. And it's a wonderful thing, because otherwise most of our time is spent on the computer trying to write up these stories. But if somebody else, while we are talking, is able to summarize it, then all the time that I have, I can spend holding the patient's hand and actually being social with them, because I don't have to do that stupid scut work. So to me, it's a very interesting sort of new path that medicine is going into, which is a very positive sign, in my opinion. And by the way, anyone who goes into medicine, to begin with, has some reason to go into this field. And 90% of the time, at least, it is not because of money or power or fame. It is because they do want to help patients. So to begin with, the kind of people who are going into medicine have a certain constitution. And styles are, of course, different for people. But the basic motivation is the same, to help the individual. Now, some doctors think that if they treat the patient and cure the patient, that should be enough. Others think that the psychic violation and healing is very important as the cure. And so for medicine, I mean, the whole idea is, it's as much about the body as about the soul. And so how aware are different doctors, and what is their style of taking these two, body and soul parts, together and combining the healing and cure part together as a result. I think it's only, I have been with tons of colleagues over the last 4 decades in the US. Basit, I have yet to meet an oncologist who didn't want to do the best for the patient. I haven't met them, there must be some. But a lot of times my patients will complain and say, oh, that one was so cold to me. And it's just the style, but it's not because the doctor didn't want to do it. So I have to defend our profession a little bit and say that it's not as starkly indifferent as people outside think doctors are. We are humans, we are moved by suffering. It's a horrible thing to see other people suffering so much. And with age and with time, it's not as if you become immune to it. It's not as if you start accepting it and doesn't do anything to you. No, because with time and age, in fact, it has a deeper effect on you. Because now you've learned to appreciate all the other meta effects that it has on the family and the community, etc. So I think that these are very complicated issues. And for young doctors and people wanting to be doctors, my advice always is, the first thing is to listen to the patient. But the second is that you will be working with many different doctors, many different specialties. Observe everyone's style of handling or dealing with the patient, but then develop your own by imbibing the best from many. And even that is not enough, because you can't have a simple algorithm that you apply to every patient. Then you need to see which kind of doctor you need to be today with this patient, and today with that patient, which part of you has to be there. So I think it's such a, that's where the individualization of precision medicine comes in, that you have to treat the person as an individual and yet take the benefit of all your experience and observations to bring it to all your faculties to bear to help that individual.
Beautiful. Well, this is, so in order to treat an individual patient, if I heard you properly, the doctor himself or herself also have to sharpen their own individuality. And one of the ways to sharpen their own individuality is to be open to and listening to and learning from other colleagues, especially other colleagues from other specialties. That when they do this, when they're open to these other voices from other specialties and other colleagues, they themselves become, they sharpen their individuality, and then they will be able to deal with individual cases, following the guidelines, but dealing with individual patients as individuals. That's one way. Well, the second part of second point, another point, right, where that integration between the artistic, the humanistic, and the empiric breaks down. One of the points is what you call the slash, poison, and burn cure. The first part of the individual and the universal is at the level of diagnosis. Here we're talking about treatment and how sticking with the established practice has really limited the way that the patients are treated. And again, these are your words. With minor variations, a protocol of surgery, chemotherapy, and radiation, the slash, poison, burn approach to treating cancer remains unchanged. It is an embarrassment. Equally embarrassing is the arrogant denial of that embarrassment. So, no doubt, the doctor as an individual is precisely as you described the doctor. They really deeply care about the patient that's there. But it looks like some borders have been put or defined that the patient has to be treated this way, and you described it as slash, poison, and burn. Now, there is enough evidence that that we have reached maybe a point of diminishing returns, or this is not. So, can you elaborate on this, what you call the slash poison burner approach to cancer treatment? And how effective is it in providing long-term relief to patients?
My colleague, closest colleague at Columbia University, is Dr. Siddhartha Mukherjee. And Sid wrote the book Emperor of All Maladies, a biography of cancer. And he got the Pulitzer Prize for this book. It is been voted as one of the best 100 books ever written in fiction, non-fiction, anything. And it is that. A stunning history of cancer. But written so beautifully, I urge all of you to read this book. One of the things Sid did is that he took the story of the Persian queen, Princess Atossa. This is a Persian, she was the daughter of Cyrus and the wife of Darius. Atossa, one fine day, feels a lump in her breast. The first thing she did is she tries to hide it. She covers it with sheets and clothing, and she's trying to hide, but the tumor keeps growing and growing. So, first of all, the stigma associated with cancer, especially with breast cancer, you're not supposed to mention it. Even until 1950s in the US, you couldn't say the word in newspapers. Such a stigma was attached to this. So what she did is she first tried to hide it, and when it became quite prominent and started to fungate, she asked her slave to simply cut it. He took out his sword and he cut it off. She survives that surgery. And then she lived for many years. She was cured. That is the first case of known mastectomy, actually. But Sid did something clever. He uses this story and looks at if Atossa was born 100 years later, what the treatment would be, and 100 years later, what the treatment would be, and brings it to the present day. And he says, from that point to today, we are doing very aseptic radical mastectomies. We take a piece of the tumor, we test for expression of hormone receptors on it, estrogen, progesterone receptors, then we look at the tumor tissue, we oncotype it, we look for the genes that are mutated, overexpressed, underexpressed. We decide whether the patient, based on this genetic markers, needs or hormonal markers, do they need hormone therapy, do they need chemotherapy? I mean, very sophisticated way of integrating molecular biology, genetics, pharmacology, radiation therapy, chemotherapy, everything. So he brings it beautifully. We share a lab, Sid and I, and we do a lot of our work together. Besides that, we hang out socially a lot together. So I attacked him. And I said, you are acting as if Atossa's fate is much better today. But for me, we were slashing the breasts of women 2,500 years ago. We are still doing the same. So he said, Azra, you should write a book called The Emperor Has No Clothes. I said, yes, it is the problem that we haven't progressed the way we should have. And why isn't anyone looking at that? Why are we satisfied with that brutal Paleolithic caveman approach? I can't stand it. You know what's chemotherapy like? Maybe some people in this room might have experienced it. Chemotherapy is like taking a baseball bat and hitting a dog with it to get rid of its fleas. It's a violation. It's a horrible treatment. Yes, we are curing a lot of people with these treatments, but we can do better. We shouldn't have to do this. So to answer your question, my critique is that the definition of winning has to change. Winning the war is not we are curing 60% patients diagnosed with cancer. My question is, you're curing with what? Slash, poison, burn. That's no winning. And the same way, Basit, my criticism of the winning culture of the West. What is the winning culture of the West? You know, everything is individualism, consumerism, productivity. The attention and the focus is on positive things, positive thinking, you know. And that does not take into account things like death, because death is non-productive. Death is not helpful. So they have even medicalized death in the form that now people die in hospitals, not at home. They die in hospitals in the middle of the night, surrounded by machines. Not even nurses are there most of the time. And so that shared experience, the communal grief and experience and seeing death as a part of life has completely been removed from our lives. And it's as if denying death is going to keep the angel of death away. You know, I had a billionaire patient the other day who came in, and when I gently disclosed to him that what we have to offer treatment, he literally got up and kicked the wall and said, "What do you mean you don't have a cure for me? I have all the money I can give you." You see, because that kind of a winning thing where acceptance of even talk about mortality is completely rejected. Because what is valued is youth and vigor and vitality. And the elderly and the diseased are marginalized in a society that is concentrated on winning. And my objection to this is that these are good things. Yes, concentrate on winning, but for God's sake, change the definition of winning. The winning should not be curing cancer with slash, poison, burn. The same way the winning is not to deny death, but to accept it and make it part of your life. You know what, Emily Dickinson, how beautifully she phrases it. Because I could not stop for death, he kindly stopped for me. She treats death as if it's a gentleman escort who has come to take her out on a date. Because I could not stop for death, he kindly stopped for me. The carriage held but just ourselves and immortality. We slowly moved, he knew no haste, and I had put away my labor and my leisure too for his civility. You know, I went through all this because cancer entered my own home. Mm-hmm. And my husband got the very disease he had dedicated his life to cure since he's 15. And even I didn't realize how painful a disease cancer is until I shared a bed with a cancer patient. And here's someone who's been seeing patients with cancer for over 20 years already. But yet that experience was so disorienting for me. The other thing is, for the next 5 years, everything I thought about, because our daughter was only 4. And so now imagine trying to navigate my way between trying to get babysitters to look after my child, or rushing my husband to the hospital, or bringing and giving him chemotherapy at home. I mean, every little decision, even if it is about to go out for 10 minutes, is directed by what's going on with him. And then he suddenly dies after practically 5 years. And I can't tell you the disorientation that came with the sudden death, because now I had nothing to concentrate and orient myself on. That whole thing, which was the driving force, the adrenaline that was making me not even think about anything, but just keep reacting and doing what I had to do. If that gets taken away suddenly, I was so disoriented, Basit. I could not listen to music. I could not concentrate on my work. My poor child was suffering. But it was like I was in a haze, in a dream. And then, you know how I reoriented slowly? 2 years went by and I was still listless and lost. And then I realized that the thing that brings me solace is reading, especially reading fiction, the great works of fiction. Because fiction allows you to stand in the shoes of someone else, experience what they are experiencing. And fiction, more importantly than that, you know, when a character is introduced in a book of fiction, we have reactions to it. You like this one, you hate this one, you want to kill this one, etc. And then you wonder why. So in fact, fiction is the best way to get insights into yourself. Not just empathy for others, but insight for yourself comes from fiction. And for me, reading poetry. So you know what I did? Over the next 2.5 years, I read the 100 greatest books of the Western literary tradition. About 50 of them I already read, starting with Aeschylus and Euripides and Sophocles and working my way all the way to Thackeray and Dickens and then to Naipaul and the current writers. And nothing brought more solace and more peace to my mind than reading the great works of fiction, reading the great works of Ghalib. And let me just recite one more thing by Emily Dickinson. The way I felt at the time before this problem, before I started reading, I felt a cleavage in my mind as if my brain was split. I felt a cleavage in my mind as if my brain was split. I tried to match it seam by seam, but could not make them fit. The thought behind I strove to join unto the thought before, but sequence raveled out of reach like balls upon the floor. That was my state of psychic disorientation, which took literally 2.5 years of a lot of other things, but the fundamental basic thing for me was reading about the experiences of others, reading the grand visions of the greatest authors, and reading our own poetry. And I think that allowed me to somehow develop solidarity, a sense of belonging once again.
Dr. Saiba, as you were speaking, and I hope I heard you right, and if I heard you right, I'm going to go back to Pellegrino's quote that we began with. Medicine is the most humane of sciences, the most empiric of arts, and the most scientific of humanities. Now, when I read this, and up till now, until about 3 minutes ago, I was reading this quote from the perspective of a doctor, from the perspective of a medical practitioner. But if I heard you right, the last 3 to 4 minutes, you were not speaking as a medical practitioner, you were speaking as a patient or someone in the close proximity of a patient.
No, what I call it is I was speaking as a cancer widow.
Cancer widow. Now, as a cancer widow, as someone who is witnessing this, so in order to deal with disease, we have to deal with disease as its victims, not as its not as the ones who are treating it, but as its victims. The scientific, the empiric, and the scientific, the empiric, and the humane or the artistic have to come together.
Yeah.
The way you describe that, how your study of the 100 great books, the key role that they played in helping you come together in a way, not as a doctor, but as a cancer widow.
Yes.
So this applies to both the patient and the doctor, that the patient also has to be, or the victims also have to. Now, with the passage of time, we know, again, coming back to the book, how the three domains, the scientific, the humane, and the artistic, have been pulled apart. So this has not only impacted the relationship between the doctor and the patient, it has also impacted the way the researchers carry out their research on this disease. And you have used the phrase, the mouse model, to describe this. And the mouse model in cancer research, again, these are your words. This is at the research stage of cancer. Animal models used by scientists to study cancer are far too simplistic and artificial, utterly incapable of recapitulating a fraction of the complex disease I have seen. Mouse models are practically worthless for cancer drug development, but funding agencies and the current scientific culture are so heavily invested in the system that nothing can make them accept the folly of their failing models. Mouse models are the real elephants in the room. This is at the level of research in cancer. And you're saying that the dominant model is, you use the word, failing. Can you please explain what mouse models are and their role in cancer research? How are these models impeding progress in this field?
I want to clarify that I'm not against use of mice for study of biology or cancer research at all. The only thing I'm against is you cannot take a mouse, kill its immune system completely, then take cells from a patient's tumor, put them in this mouse, they start to grow. Now, this is a very different environment in which they are growing than the human body. The immune system has been killed, and this is a mouse, not a human. And then you are going to treat it with whatever new drug you have developed, and the treatment works, and the mouse is cured, and you declare victory, and you say, I'm curing this type of cancer, except when that drug is brought to the bedside of the patient suffering from that disease, it fails 95% of the time today, and the 5% time it's declared a success. It should have been declared a failure, because all it's doing is improving the survival by a few months for 20 to 30% patients. None of these things are curative. The only cure for solid tumors really is surgery. You still have to cut it out. There are very few small lumps and things superficial which can be treated with radiation, but chemo can't treat any of the solid tumors. Chemotherapy is treating liquid tumors. And that too is a horrible treatment for them. Yes, it cures a few, but very few. So the question comes up over and over that what are we doing wrong? Well, what we are doing wrong is we are not studying humans. I'm told that we can't study humans because we can't do same kinds of manipulations that we can perform in an animal model. Then we can kill the animal and look at the effects of whatever we were manipulating. Yes, you can't do that, but then don't ask those questions. That's my simple answer. Look, the only good news we can give a cancer patient is, don't worry, we found it early, so we can help cure you. What does that mean? Detection, early detection is good. But again, the definition of early detection right now is stage 1. But stage 1 requires slash, poison, or burn. I'm saying you need to redefine that. You need to say, no, I want to diagnose cancer at a stage where even lifestyle changes would prevent further progression of the disease. where you don't have to use these primitive therapies. What is that stage? Well, inception of cancer. We need to stop chasing down every last cell, and we need to revolutionize methods of early detection. Let's not rely on mammograms and pap smears and PSAs and colonoscopies and CT of the chest occasionally to give us results. No. You know what people tell me? Well, early detection hasn't worked, because you know what the statistics are? In America, we spend $27 billion a year on these 5 screening tests, which I just mentioned. $27 billion. Out of those that we test, 9 million tests come back positive. But a positive mammogram doesn't mean the person has breast cancer. Now you have to go in and biopsy. A high PSA doesn't always mean person has prostate cancer, could be from some other reason. So now, out of those 9 million that we found positive, 8.8 million turn out to be false positives. That individuals on whom you had a positive test were dying of anxiety, but then the biopsy proved that, as Woody Allen says, the 2 words that make humans happiest in this world are, "It's benign." So people are so anxious until they hear. I'm telling you that for $27 billion a year, we are basically diagnosing 200,000 cancers. Because out of 9 million we found positive, 8.8 million were false positive. Is this really efficient way of spending money? But that's the criticism people say. Well, you see, we have been using these early detection tests and still people are dying at the same rate. Well, so get better tests. And you can't get better tests by studying animals. You got to study humans. So the question is, how do you study humans for early detection? Who do you know will get cancer? I mean, if I start following one person, they may not get cancer for 30 years. Well, there are some people who are at high risk of getting cancer. I started my career studying acute myeloid leukemia. Within a few years, very clear to me, in my lifetime, this deadly disease, so malevolent, so malignant, not going to be cured. And I was right. We are using the same 2 drugs we were using in 1977, we are using in 2024 to treat that deadly disease. So in 1984, I said to myself, we have to find this early. That's the only way. And it turns out there are people who have pre-leukemic conditions. And that's what I started to focus on. Pre-leukemia is what Nudrat couldn't pronounce. Myelodysplastic syndromes. That is pre-leukemia. I focused on these patients who just present with low blood counts. They don't have leukemia yet, but if you follow them, 30% will develop leukemia and the others will die of just worsening blood counts. So I started following these patients, and as you pointed out, I started saving samples on these patients. In 1984, and today I have the largest tissue repository in the world of these diseases, 60,000 samples from thousands of patients that have been longitudinally obtained. Have not wasted them. I've been waiting for the best technology to develop to interrogate the samples in a comprehensive way. Not just do genomics, but genomics, transcriptomics, metabolomics, proteomics, multi-omics, and longitudinally to trace the disease back to inception and then use that as a test in humans to find cancer early.
Well, again, the humanity in all of this, for you to save the samples. How did that even occur to you? 1984, you were early stage in your career, I guess. If you begin in 77, you were a junior doctor. How did the established authorities treat you
Well,
when let's say when you did the first 10, and people find out, okay, Azra is doing this thing. She's can you say something about that, please?
Well, first of all, what happened, Basit, is because I was a stupid immigrant. And I was just not trained in that system. If I had gone to school in America, next move would have been to try and develop a mouse model of pre-leukemia. That never occurred to me because I had gone from Pakistan. I said, if I want to cure this disease, I better have samples to study. And we could just store samples, and then slowly more formalization and rules and regulations appeared. But that's fine. I mean, we continuously have to, in fact, I love guidelines and rules because that keeps us vigilant about everything. So we are we're big stickler for rules. So I think it happened so naturally for me that I just was saving samples, and then that kept growing bigger and bigger. And all the time I was taking them out of freezers, 200 patients at a time, 300, and publishing continuously on findings on human samples, but always saving some extra. So that today we can go back 35 years and pull samples of people who died within 6 months or who survived 10 years and compare them and say why, what was different about them.
So you did this. You could not have done this if you had stayed within the box. This is thinking outside of the box. And obviously there were other colleagues at that time and many colleagues before who could have done the same thing, but this idea never occurred to them. And so I want to now go to the next.
Well, that's why in the US, the other title for the first cell, my book, is The Satanic Verses of Medicine.
Well, now we will get to that. Okay, now what makes them really satanic? Because there's we're all part of an institution. None of us can escape an institutional setting, and you're practicing this in the institutionalized medicine, and with every institution there's an established establishment, deeply entrenched establishment. And you describe this establishment and what it has done in terms of narrative building, and then the impact of the narrative building at the level of research, at the level of treatment, and at the level of practice. What this establishment has done. Newly minted key opinion leaders, with the blessing of their scientific mentors, inherit the exclusive power to define rules, monopolize grant funding powers, and reward each other with perks the field has to offer. Adding a final insult to injury, these little arrogant cliques manage to hijack the entire narrative in a field. Young researchers and all oncologists must think differently, to question dogma, to reject the deep-rooted archaic traditions, to discard the existing inadequate research models in order to solve the cancer problem. End of quote. These are your words. My question: can you elaborate how the narrative in scientific domains and universities is hijacked? And if this continues to happen, if this does not change, what are the implications for the future of medical field and other disciplines?
Yeah. Well, you left out my favorite sentence about this.
I'm sorry.
Which is that I say something like, recently a young oncology researcher from another institution came and delivered a lecture at Columbia University. His ego was so dense that light was bending around him. They are so full of themselves that, oh, Dr. Raza, you belong to the old school. They come in riding on their white stallions, and they're going to go and deal with this issue of cancer with their new technology and research things. And that's the kind of arrogance that sort of denial of history and denial of the complexity of the disease itself, which creates a problem. The other problem is that in any given field, the progression is pretty similar, whether it's the arts or the sciences. You begin everything with good intentions. But then what happens is, as the field is progressing, it becomes more and more ossified rather than opening up. Why? Because there are two people who can take the risk. Either the young investigators, but their problem is if they think differently from the field, then their hypothesis, their idea could turn out to be wrong. And you can't afford to risk being wrong when you're just starting a career, because your salary depends on that. So young people can't take the risk of changing from the old mold. The older individuals, the investigators who have been in the field for 20, 25, 30 years, they can't afford to change because that's the only thing they can do. So they have to perpetuate that idea. And they're the ones mentoring the young people. They're the ones sitting on all the granting agencies. You know what really shocked me it's really sad, but one of the young fellows who I have trained for many years, since he was a resident and a fellow, came to me because he interviewed at many hospitals for a full-time job. And he said that basically the question most people would ask me is, okay, as an oncologist, do you want to publish in the New England